Ah, okay, good. All right. Hi, thanks. Yeah, Brian Bizik. I work at Terry Riley in Nampa primarily, sometimes at the other clinics. And good to see everybody. And this is fun for me to do. I hopefully this is very helpful for you if you're in schools. I will make a mention about schools. I saw a lot of school people, and there is a program now both for epinephrine in schools if you're not familiar with EpiPen for schools, and there's one for Neffy as well. So I'll mention those at the end. And glad to have you here. I want to make this as practical as possible for everyone involved no matter where you practice, because this is something we see. And so I'll go ahead and jump in. Jocelyn, am I okay just to keep going? Yeah, good. All right. So my name and contact information is up there on purpose. You are free to reach out to me if I can help out in this area. You have a resource. Text me, tell me who you are first time, or I'll say new phone, who dis, and then you tell me who you are. And then I'm happy to answer questions. So love to do that and make this a little less scary. This is one thing that can be really scary. So we want to make it less scary. My goal today, all right, let's talk about big picture goals are trying to get over the hump of actually calling this anaphylaxis. There's so many definitions. And actually, to date, nobody agrees at all about the definition of anaphylaxis. So that's a problem. But the consensus guidelines I'm going to show you, there is a pretty good consensus by most people about how to see it. It's happening in front of you. This is something that's occurring right there. How do you call it? How do you feel gutsy enough to say, yep, that's anaphylaxis, and then decide what to do? There's only one treatment. There's only one thing, and how you give it has changed, but the medication has not. It's epinephrine here. I just did a conference in England. They were from England. I was on Zoom. I wasn't there, unfortunately. But anyway, and they only call it adrenaline. They never say epinephrine. So it's fun, but it's the same thing, and that's the only treatment. So what about other stuff? Do I need to give lots of prednisone for a couple of weeks after anaphylaxis? We'll talk about that. Guideline recommendations. We have two good summary statements that have come out in 20 and 23, and I'll show you those. And then some tips and pearls about giving epinephrine. And ultimately, or at the end, I'll get to Neffy, which is a new nasal epinephrine, which is just a nice option. It's still the same medication. It's still a nice option for us. And it just changes some of the perspective of, do I have to inject a needle? Do I have to stick a needle in my leg? Or do I have to stick a needle in my kid's leg? If I had another option, would that make me more likely to provide that medicine? And that's the whole goal behind that, behind a nasal epinephrine. And there's two powder epinephrine that will be delivered nasally that are in stage 3 trials right now. So those may be out next year, 2026, not 2025. So there may be new things coming on the scene soon as well. All right, that's some of my disclosures. I don't work with any of the epinephrine companies at all. No disclosures. I don't have stock, unfortunately, in anybody. This is the 2020 guideline, and this is the 2023. So these two tried to bring together allergy people that don't agree on anything very often. And so the two big groups are the college and the American Academy of Asthma and Allergy Immunology, Quad AI. And those are our parent groups. Those are the groups that I am involved with. And they did a consensus statement. So these are the guidelines and the practice parameters trying to help people all over decide how to do this and how to treat it. So if you want to dig a little deeper, this is the latest one, and you certainly could look that up. Very well done, very well written, and it's done in an easy to follow manner. So it's a good talk. I mean, it's a good paper to read if you are really wanting more information. All right, dig in. Anaphylaxis. This is a little sad. I know I shouldn't start a PowerPoint with a sad slide, but in a few seconds it was ill. It became distressed and panting. It could scarcely drag itself along. It lay on its side and it passed and it died. This was a dog. I'm sorry. This is terrible. I'm starting with a dog thing, but this is true. This happened. It was a long time ago. Charles Richet, this was his first study. He gave dogs this sea anemone toxin and nothing happened. And then a few weeks later gave it again, and some of them had this happen. And he said, well, they used to be protected. They had phylaxis, and now I took that away. I gave them the toxin one time and I took away their protection. So that's anaphylaxis. And they lost it. So that was the idea. It's still a good word. It still works, but very different thinking, right, on how it happens. And he won a Nobel Prize. Look, it even has a stamp named out. Look at that. I have that stamp. I just couldn't find it. Can't believe I was disorganized and couldn't find my stamp, but I do own that stamp, I swear. He won it. So that was the first time somebody looked at this and said, we can take away protection. It's a little different, right? We know that anaphylaxis, what is it? Acute allergic reaction, widespread symptoms, 2 or more systems, okay? So this is what's going on. You have a patient in front of you, or you're trying to make a decision and you think there was an exposure, or you're sure there was an exposure. I just had a patient come in and say, I ate a muffin with walnuts. And I'm allergic to walnuts. That was the first sentence. Okay, so all of the doubt is gone about what just happened. And it wasn't walnuts. I changed the nut to protect the innocent. But anyway, it was that. It was, you could imagine. And anyway, so that took away. So she had an exposure. I know she had an exposure. And what happened? In front of me was a patient who was evolving. She was having symptoms that were evolving. And if they evolve and there's two body systems or more, that's anaphylaxis. That's the definition. Skin and GI and respiratory. If there's an evolving reaction, you think there was exposure or you're sure there was an exposure, that and it involves two more systems, that's anaphylaxis. Be confident that if you see that, that is an anaphylactic reaction. What you do may be different depending on where you're at. When I worked in an allergy clinic for a long time, we didn't. By the way, I didn't say that. About half of my career has been in the allergy world and half has been in the acute care kind of general practice world. So I've tried to bring those two worlds together. And in the allergy office, we often didn't treat with epi right away, but we had it right there and we had nebulizers and we knew the patient and we knew that I knew their eosinophil count. So I knew things that helped me decide what I needed to do. But a lot of times you're just going to treat. Now, the guidelines say this, and I say it 2 or 3 times, that you do not have to have any of these to give epinephrine. You do not have to meet any criteria. If you think it's happening, give epi, and the guideline says that over and over. There is no criteria needed to be met to give epinephrine. If you think it could be happening, give it. NIAID, they have a little bit different take on it, but it's essentially the same thing in that middle box. 2 or more of the following, right? They have an exposure, 2 or more body systems. They also note that if there's hypotension, then you're done, right? You had an exposure with hypotension, you're going to go ahead and treat that as anaphylaxis, regardless of whether they have hives or not. Now, here's the progression, couple thoughts. So histamine, there's other chemicals, right? They're driving this. But how much histamine is going to be released? I ate a walnut, I ate a muffin with walnuts for breakfast, and I'm allergic to walnuts. Okay, how much histamine, how many mediators are going to be dumped in the next 15, 20 minutes? I have no idea, right? I don't have any idea what's happening. I don't know how much histamine she's going to dump. And well, how much histamine is needed for anaphylaxis? I don't know. I don't know, and you don't know. We don't have any idea how much is going to be released and how much it takes. I don't know. I know I have an evolving reaction after a likely or confirmed exposure, right? And I have 2 or more body systems. That's it. That's the line in the sand. You cross that, it's anaphylaxis. And meeting criteria, not needed to give epi. So I'll keep saying that, but you don't need to meet any of this. But if you're trying to decide, is this anaphylaxis, that's how to do it. And you don't know. You don't know where this is going to go. And so and it doesn't matter. Who cares how far it's going to go? Exposure, histamine, and other chemicals are being dumped. I've got a reaction to that, and I don't know where it's going. I need to intervene, okay? 2 definitions, just in case you're familiar. I mean, not familiar. Refractory just means that that you had to give 3 or more doses and it's still having symptoms. And then protracted, if it goes more than 4 hours. So if you see those 2 definitions, those 2 words, that's what those 2 terms mean. And they're good to kind of be familiar with. Doesn't happen very often. I've actually never seen protracted in 20 years of doing this. Is it anaphylaxis? So here we'll do it like a made up, completely fake case study. 12-year-old male with an insect sting, stung once. So just one time, might have been a honeybee because they sting once and they tend to, not always, but leave the stinger behind. At a park, had the following: hives. Okay, so he's got skin, tongue felt thick, but didn't look swollen. Cough, a little bit of wheeze, chest was tight. Runny nose, sneezed once, felt nauseous, was going to throw up, hands and feet were swollen. Yeah, okay. That would be anaphylaxis, and I don't think anybody would struggle with calling that anaphylaxis and giving epi, all right? What if 12-year-old male had an insect sting, stung once, and had hives, tongue felt thick, didn't look swollen, and cough? And that's it, and a wheeze, and a little bit of chest tightness. Yeah, right, that's anaphylaxis too. Absolutely, right? I don't need GI, I don't need edema. I've got this. Same kid, amazing, poor kid. 3rd time he's been stung. Hives, tongue felt thick, didn't look swollen. Yeah, that's still anaphylaxis. It still is. You may choose not to manage this differently, these 3 scenarios, but these are still, they meet criteria. He has cutaneous and there's a GI involvement. There's enough histamine that I've got hives that I can see. I've got dilation of capillaries and I'm getting blood pooling at the skin that I can see in the form of hives. And I've got something going on in the mouth. And because he's telling me this. So this is still anaphylaxis. So it doesn't take as much as we think sometimes. What brings it on? So the mediators, mast cells, are the cells that are, there's other ones, and basophils play a role, but these are the ones that are driving this. They are just sitting there waiting. They're waiting for my patient to eat walnuts or somebody to have exposure to yellow jackets or, stepping on the nest on the ground and then they get stung a few times. So these are just sitting there waiting. They dump everything as soon as they're given the chance. So with all atopic diseases, and this one, it's a rapid dumping of all these mediators that are sitting there waiting, and they're waiting in the tissues that are exposed, right? They're in the nose, they're in the respiratory tract, they're in the skin, they're in the GI tract. Histamine's a major player, but there are others. We just talk about histamine because it makes it easier. First time exposure may produce mild. Once they're sensitized, even a very small amount can trigger this. All right. So this is cells ready to go, sitting in all of the tissues where we're going to get exposed, dumping histamine. How much are they going to dump? I don't know. What's going to happen? How much does it take to have a life-threatening reaction? I don't know. I just know that they had an exposure. They're dumping these chemicals. And because of that, in front of me is a patient that's evolving, and they have 2 or more body systems. That's anaphylaxis. Most occur quick. They're usually very quick, not always. The next slide shows you some time, but they can be later. And alpha-gal, if you're not familiar, is very interesting. Probably the coolest thing. We should do an alpha-gal talk next. I will come back. It's very cool. And it's the one that's delayed. So for people that have an allergy to red meat, so if you ever have a patient that sounds like that, anaphylaxis at 3 in the morning after being asleep for 4 hours, it's alpha-gal. If they really had that reaction, might have just been a nightmare. All right, the allergic response. This is my only physiology little diagram, but we have IgE that's ready to go and it's sensitized to whatever, peanut or whatever. And the cross-linking happens on the mast cell. All of this stuff is dumped. So that's the allergic response. And this is ready to go in the tissues. It doesn't take, once you're primed, these cells are there ready to go. All right. So we know this is happening. Histamine's the problem. It's one of the problems. Okay. What are we getting? All the blood vessels are going to get bigger. They're just going to get bigger. The blood vessels themselves are going to, the endothelial lining kind of pulls apart and you get this extravasation, this third spacing of fluid, movement of cells that shouldn't move and proteins that shouldn't move out of the blood vessels. And that's all the permeability. All of this, I mean, your immune system is trying to protect you, right? It's, hey, you just ate a walnut. That walnut is going to kill you. I know, I'll save you and I will make you vomit it up, or I'll allow our immune system to leak wherever it needs to go. So this is all trying to help you, but it's an over response to something that's harmless. Heart rate, smooth muscle contraction. So I can get wheezing, tightness in the airways, GI stuff. All of this is an attempt by the immune system to protect and repel the allergy, right? If it's in my nose makes snot because I have allergic rhinitis. I'm trying to get rid of that allergen. It's a protection. Anaphylaxis is an over response to a harmless thing that's causing all these problems. Glandular mucus secretion, so like goblet cells, you remember pseudostratified columnar epithelium, remember that from histology? All those cells are ready to go and they're going to get stimulated to do their thing. If their thing is to make snot, that's what they'll do. Make mucus, that's what they'll do. All of these systems are ready to go and protect you. And when they all go off at the same time, distinctly not helpful. It's kind of like me. I think I'm helpful, but my wife tells me I'm generally not helpful. So that's just, I am anaphylaxis. Vasodilatation, erythema, nasal congest. I don't know, that's not a word. It looks like it got cut off. Hypotension, permeability. So that's urticaria, hypotension, smooth muscle spasm. So asthma, wheezing, cramps, diarrhea. So all of these things are happening and this is the outcome, right? So I can get a flare up of allergies, runny nose, asthma, all of this can be happening. I don't see a lot of sneezing. That would be interesting if people just started sneezing. I don't know that I've ever had anybody have that as an initial manifestation. So urticaria, that the thing you're going to see most is urticaria, and I'll show you numbers in a second, but it is hives. You're going to see it. And the upper chest right here, face, so in the allergy clinic, if we were concerned about anybody, we always exposed right here. So if they had like a turtleneck on, we would put them in a gown because I want to see this chest. This is where it always happens right there. So this is one of the things you can see early. And while GI can be really early, especially in adults, the walnut person that I was mentioning before, actually, she only had GI for about 25-30 minutes, only GI, nothing else. I just sat on, I was watching her, and then she got a hive, and then she got epi in that order. Well demarcated, that's what hives are. Lasts for a while. They can go on even after the anaphylaxis. So that's urticaria, classic urticaria. Lots of dilatation, skin is red, lots of these little bumps that you can see that are pretty itchy. Angioedema is different. This can be histamine or bradykinin induced. The only reason I brought this and put this in here is that you can get angioedema. This is angioedema. If you struggle kind of the difference between the two, hives are in the skin. I mean, excuse me, back up. Hives are on the skin. So urticaria hives are kind of, they sit on the skin, and angioedema is in the skin. And that's the way you can tell. This is, I'm getting fluid, but I'm not getting it in the skin surface. This is urticaria. So, and if you're charting this and you're putting it down after, if you can put that it's urticaria with or without angioedema, for us later on, that's really helpful to see. Because if there's angioedema involved, it takes us down a very different pathway in the diagnosis and treatment sometimes. So, because it's bradykinin, it's a different mediator. All right. So anaphylaxis. Yeah, you got a question?
There's a question in the chat. Wouldn't peanuts be more common as a precipitation than walnuts?
Yes, they are. They are here. They're not everywhere, but yeah. So peanuts in the nut world, peanuts are the most common food allergy that we're going to see that results in anaphylaxis outside of milk. Okay, so I won't get into which is more, but yes, much more common. I mean, it's kind of interesting, and I blame Nutella for hazelnuts, but hazelnuts made our top list 2 years ago or 3 years ago. That's all Nutella's fault because Nutella is amazing, and let's just be honest, it's amazing. And so hazelnuts, cashews are gaining. Brazil nuts never will because they're terrible. But yeah, so peanuts is much more likely. But remember, I changed the nut on my story because I believe in HIPAA fully or something like that. But anyway, so yeah, but peanuts would be more likely. And just peanuts just more likely to cause anaphylaxis out of all the nuts. That's the one you're going to see most often. And remember, expose kids to peanut early. It's another talk, but if they have eczema, please give them peanut protein at 4 months or earlier. And that's another, reach out to me. I can help you with that. So
there's one more question.
Yeah, I like it. No,
Did you want to ask your question?
Go for it.
Here, I'll just read it. Milk can cause anaphylaxis, question mark.
Yeah, it can. In fact, in a couple of slides, I'm going to show you another sad slide. I need to get rid of my sad slides, but yes, I'll show. So yes, it can. Actually, most common single food that causes allergies worldwide, that causes anaphylaxis, is milk protein. It can. It is also, we're still about 60, 70%, maybe a little more, outgrow milk allergies. So you don't really outgrow nut allergies very often, maybe 10, 15%. Depends on it's very different. This is very regional, by the way, across the globe. So what I'm giving you is kind of US and even Western US numbers. But yeah, so it for sure can. Just most of the time, milk causes mild symptoms, but it still can cause anaphylaxis, and it does. Yeah, good questions. I just can't see your chat, sorry. So please throw them out or just kind of yell at me, that's fine. All right, so anaphylaxis, where are we at? It's a severe reaction. It occurs suddenly. If somebody ate and then had a reaction 12 hours later, it's not anaphylaxis, unless it's that one alpha-gal. And scombroid I didn't mention. Scombroid is a condition where you actually eat histamine. So I'm not reacting. I'm not making my own, but I ate. An animal had histamine and I ate that animal because it was improperly packaged. You're probably never going to see that. But alpha-gal you will. But all others aside, 99.9% of the time, it's going to be pretty quick. Death can occur fast, and I'll show you some of the numbers. And it affects a lot of systems. And if it affects 2 or more systems, that's anaphylaxis. And you need to be able to call it that and be comfortable and say, yes, this was anaphylaxis. That's what happened. What we do about it, okay, let's talk about that in debate, but let's treat that. This is the milk. I said this is the very sad one. This is a milk. It was a prescription toothpaste that had milk protein in it, and this young lady passed away of it. So yes, it can. This is the case of Reese. I'm sure many of you were familiar with this. This happened just a few years ago where she had a baklava. She had a baklava product that had peanut in it and didn't know about it. Her mom has been amazing and been a very big kind of proponent. Epi first, epi fast. She's talked about that many times, and it just gets down to providing epinephrine quick. So that was just an Eagle a few years ago. And that was peanut, but it was kind of hidden in a food. She didn't know it was in there. All right, that's where we're at. Rapid recognition and trying to figure out what's going on and doing it pretty quick, because if they're going to have a bad outcome, it doesn't take that long. So if they're going to have a respiratory or cardiac failure, food, it's about 30 minutes. Venom, it's about 15. And medication, it can be very, very quick. Okay, so you can just see these happening very quickly. With kids, food and stinging insects, and then adults, it's medication and stinging insects. And we have lots of therapies. I'm not discussing therapies at all. But if you have anybody with allergy to venom, whether it's Hymenoptera insects, honeybee, fire ant, we don't see a lot, but there are treatments for those, and you can make those go away 90% of the time. Those are treatable. You can make them be gone, or gone to the point where you can tolerate a sting usually. So there is therapy for that. Recognition, you just need to see it. Where is it going to come out? Cutaneous most of the time, respiratory, sometimes GI. The older, as just a side note, the older the patient, the more likely the GI. This is kind of everybody. And I also don't think I spelled cutaneous right there. I probably stole this slide, so somebody else did it. But anyway, this is the numbers. This is just another way to look at the clinical features of how often this happens and what to look for. Biphasic, I'm going to talk about next in just a second. So we're going to get to that. I think that may be the next slide. So those are just how you're going to see it and what they're going to present with. These are the triggers: food, insect stings, idiopathic. That's a big one because it's hard to know when you don't know what it was, then you don't know what to protect against, and they're more likely to be severe. And then exercise, and then allergen. I don't know what these are all allergens. I need to crop that out of there. Just pretend it's not part of the table. All right, so that's kind of the triggers. All right, and biphasic, just a couple of slides on this because it comes up. This is the thing I get asked a lot about. Biphasic, let me go to the next slide real quick. Recurrence of anaphylaxis after treatment and after they got completely better, but they didn't have any more exposures. So this is something that you learned about in school. We're afraid. And this is one of the things, this is why we traditionally sent people to the ER every time. We're going to come to that question in just a second. Do I have to send them to the ER every time? But this is why, and this is kind of what it looks like: symptoms, and then a period of time, and then another one. Now that 1 to 8 hours is kind of an average, and Dr. Golden, who put this out, this has since been updated again, and it's now says 1 to 44 hours, I think, or 46, but because it just seems like they can happen later and later. That's what biphasic is. This is how often it happens. I put that 5 to 8%. I think I'm going to change that because this year and 2023, 2 published studies kind of think making it closer to 4 to 5%, which doesn't make a big difference in the general practice world, but it's probably not quite as common as we thought. And you can kind of look at this. It all depends on how you qualify it and what population you have. $1 million question though, how do you know? Okay, so we're looking at anaphylaxis, we're seeing a reaction, 2 or more body systems, it's evolving. I'm going to be confident and say that's anaphylaxis because I know they're dumping histamine. I know that's going to keep going. I don't know how much, but I know it could get bad. Reese was in the back of her car when she started having all these symptoms on the way to the ER. It kept going. So this can happen. Well, if they get better and they're treated, who's at risk of having this terrible biphasic thing? Okay. This is just the odds ratio. So if you want to know who's at risk, this is the best that we have right now. Unknown etiology, 1.6. Okay. This is the big one right here. More than 1 dose of epi. So if they had to have 2 doses or more, their risk skyrockets. And I did a workshop with some groups in Canada, and they only use this criteria. They don't list anything else. In fact, the only risk they list anywhere in all of those official documents in Canada is more than 1 dose. So it's a big one. Wide pulse pressure can be an issue. Skin symptoms that are more than 20% of their body surface can be a big deal. Time to the first epinephrine. So if it was delayed, and the study puts out this guideline that the average for the biphasic group was much longer for the monophasic. So severe, delayed, and I don't know what caused it. Those are all big ones. Drugs are higher risk for kids for biphasic. Food is lower, right? And that may make sense a little bit because you digest that food. And severe anaphylaxis, the odds ratio 2.1. So highly variable, but if somebody had 3 systems involved or more, it seemed more likely. That's just the risk. So anybody can have it, probably about 5% of the time. But if you're talking to patients, if you're talking to kids at school and they had a reaction and it was severe, just know, they're at high risk. They need to be monitored. They need to be watched. You need to be very diligent about those ones, okay? Second, how long do you watch this patient? This is more for an acute care setting if you were deciding to keep them. And kind of the guideline is 6 hours. That's not official, but if you keep people for 6 hours, if they haven't had a biphasic in 6 hours, most are probably okay at that point. So that's just kind of a rough number because I get asked well, how long do ERs need to sit on them? Is there a number? And this is kind of the number that you can get. One thing there was the report that came out this year did say a couple things that are encouraging. One is those people that had biphasics, almost none of them even needed treatment. So they had symptoms again, but 75-ish% weren't treated. And there was no deaths in the big trial. And there was like 200,000 total patients enrolled in this thing, or that they pulled out of the record. So no deaths, and a lot didn't need treatment, but it still happened, and some did. I had a patient, we treated him anyway, and then I sent him home, and he called me about an hour later from Costco. He was in line at Costco, and he said, I think that thing is happening. I'm like, call 911, come here. We were just not too far away. And he says, no, I'm not getting back in line here. And so he checked out of Costco and then came. Don't do that. Don't do that. Anyway, that really happened. All right. Do we give steroids and antihistamines to prevent biphasic? Well, no, you don't. I mean, you can give them all you want. You can do that, and I'll talk about it in a second, but it doesn't prevent. We don't have anything right now. We don't know if anything out there will prevent a biphasic reaction. So if you give prednisone or give antihistamines, you can do that, but don't say it's to prevent biphasic, all right? Because it's not. It doesn't seem to do that. All right, so I'm gonna take a quick breath, see if there's any questions, if you got anything else out there. We're in the home stretch, I promise. Okay.
There's still time. So does anyone have questions?
Oh, okay. Well, I'm not done. I still have 200 more slides. No, I have a few. But okay, so if there's not questions, I'll keep going. So we got to treat. We got to do something with these patients, right? Anaphylactic reaction, do not recommend. So treatment, ABC, of course, but I would actually say this is the one case where ABC gets set aside. You don't normally have to decide which one you do. Give epi and then do ABC, all right? Because if they need epi, if somebody is going to pass away of anaphylaxis, there are some risks. The big one is no epinephrine or not giving it. So that's like nothing is bigger than that. Giving the epi, giving it quick, don't delay it. If they do have asthma and they're having an asthma flare before, that's a big risk factor. In the allergy clinic, when somebody comes in for their allergy shots, if they're having an asthma flare, I have to see them before we give the shot, but I almost never give it. It's just there's no reason to. If they're having a flare, something's going on. Treatment, there's only one. That's nice. Epinephrine is the first line treatment. Nothing else works. You can give IM sub-Q, or I need to add intranasal to that. Antihistamines, bronchodilators are not first line. Don't ever, I mean, you can give Benadryl, but don't. First of all, I would suggest Benadryl is taken off of everyone's list to give ever. Diphenhydramine doesn't, it's not good. It isn't quicker. It's not better. It crosses the blood-brain barrier, causes problems cognitively, school problems, driving problems. Yeah, anyway, just don't give it. Antihistamines you can give, but once epi is given, you can monitor and decide if you want to add other things. I will say, and they don't prevent biphasic. What we do, I mean, I'll say this is still kind of a pretty common thing. And I'll also in a second tell you that there's no data to support this. So I do often give prednisone for a couple of days, a low dose to kids and adults. Maybe I'll give 40 milligrams for 2 days. The cetirizine ranitidine, I think it makes sense. There's no downside of giving cetirizine. You can do 10 milligrams twice a day. Ranitidine. So you got an H1 and an H2 blocker. By the way, those two, that's what you give for like urticaria. You can give that and it works very well. Very inexpensive, there's no sedation with those for most people and no downside. So if you want to leave off the prednisone, that's fine. This does seem to help anaphylaxis is not a seizure, but I like to think of it, and I was trained, the allergist trained me, said it is a postictal. Think of it postictal, right? And they have some lingering kind of miserable symptoms, even if they're not at risk. And that's what we're trying to treat with that. You can step up their inhaler, say instead of every 4 hours or, as needed, let's go ahead and do your albuterol 3 puffs or 4 puffs every 2 or 3 hours for today. And then tomorrow go to PRN. That's very reasonable. Did that all the time. Refill their injectors. Highly customizable. You can back off. And many people just aren't doing this. And that's fine because the data doesn't really support it. And like whether or not it helps, I think we need more data to say this really makes a difference. But it makes me feel better, right? I mean, I feel better. It's like when they take their blood pressure medicine, I feel better. They don't feel anything, but I'm happy. Side effects of epinephrine, that's actually not a good title. It's not. The effects, it does everything. So this is the take home. All you need to know is everything. There isn't anything in anaphylaxis that's bad that isn't improved with epinephrine. So whatever symptom you're concerned about, whatever body system you're concerned about, it all gets better. Now it's a fight, right? Your body's trying to shut things down. It's trying to make airways smaller, and the epinephrine is trying to do the opposite. So it's a battle. So which one wins, whether I need to do 2 doses or whatever, but they are fighting on all fronts simultaneously. So it does everything. Only usually takes a few minutes, but it can take longer. We had an anaphylaxis to a vaccine not that long ago, and gave the epi, and then I kind of sat her up a little bit, and I watched, and the hives, like it was like like draining out of like a red liquid out of a cup or something. It just, the hive just disappeared. It was very interesting to watch. One of the quickest ones I've ever seen. GI tends to get better pretty quick too, usually, which is good. So that's what happens. Epinephrine works. It reverses everything. You just got to be confident in saying, this is anaphylaxis. It's two or more body systems. It's evolving. I'm going to treat you and I'm going to give you epinephrine. If you should give epi and they didn't need it, what happens? Yeah, nothing. Nothing happens. Nothing bad happens. You can give it to everybody. This is a nice summary of like the contraindications, which are zero. I was going to have a slide that had nothing on it and just bring it up to make the point. But let me take that box and make it bigger, that gray box, and just blow it up so you can see it. But based on the current data, there's no contraindication at all. You can give it to anyone. And worrying about the contraindications, concerning yourself with what's going to happen, it doesn't do anything. It only makes things worse. So don't worry about it. Give it. Don't hesitate to give it. I injected myself one time during a talk, accidentally in my finger. It was fine. Nothing happened. I just talked faster, which was helpful. So don't hesitate. 3-year-old, 93-year-old, they got 4 pacemakers. They got a pacemaker on top of their head. You're going to give epi. Don't hesitate. They had an exposure and an evolving reaction in front of you that's 2 or more body systems. Give it. All right. This is from the guidelines. Serious adverse reactions are not existent. So don't worry about it. EAI is epinephrine autoinjector. Just provide it and encourage them to use it. This is a list of some of the epinephrine autoinjectors. If you want to look, those are out there. They have videos on most of those and how to give it. Sorry, gross picture kind of if you're eating lunch, but this is what happens when you try to hold an EpiPen too long. So one tip I would give, I don't have an epinephrine autoinjector, but if you want to give it, and some people say hold it for 10 seconds. I mean, hopefully that's not anything any one of us are telling patients, because holding it, a squirming kid, this is what happens. Well, can happen. This is pretty rare. But so what do we need to do? Let me take this study and just take that conclusion and make it bigger so you can read it. At top, no linear relationship exists between time and how much epi gets in for the epinephrine autoinjectors. So holding it 1 second seems to be as reasonable as 10. So I just tell patients, look, you're gonna provide it. You're going to hear the click. You're going to see that it's gone in. Once you've registered that, you're at about 2 seconds most of the time. We've timed it many times, and that's fine. Like if you do that, that's fine. If you think somehow something happened and it didn't go in, give another dose. It's okay. I mean, I don't want to give 2 doses back to back if I don't need to, but I'd much rather give 2 than none. And there's no reason to worry about it. If you have if you have a junior and it's adult, give them 2. If you have an adult and it's a kid, give them the adult. Okay, those are fine. Actually, the dosage probably needs to be a little bit higher anyway for kids. I'm not saying to do that if you have the choice of providing the right one, you're going to do that. But practically speaking, they have a potentially life-threatening reaction that you can stop. So provide epinephrine if you can. Activate EMS if they're right down the street and you want to wait. That's fine, but just try to provide that. Okay, so that's a little bit on the epinephrine devices. That doesn't include, I have the nasal thing here I'm gonna get to in just a second. These next couple, these are the last few slides. These next slides are for reference. There's lots of words because you can read them later. But this is the guidelines for 2023 said, hey, you may not have to go to the ER. Going to the ER or calling 911 after administering epinephrine was a deterrent for about a quarter of the people that did it. So if you said, for people that didn't, so you say, hey, you didn't use your epi, why? A quarter said, because I didn't want to call 911. During COVID, this came up. And so this is more of a consensus statement than anything, but we believe that suggests that you counsel patients that immediate activation of EMS may not be required. If they have complete reversal of symptoms, it seems to be holding, they have another epinephrine autoinjector ready to go, and they're not that far, and their car works. There's some things to think about, but if that's the case, then you're fine to stay at home. These next 2 slides are just for you. If you're curious, if like you want to decide whether this is something you tell your patients or the kids at school, this is the kind of the green, yellow, red stoplight of when you should think about keeping them at home and offering that as advice versus not. So you can read through that. And then this is just another one, a list that you can read. Who should stay at home or who could stay at home if that made sense on the left. Who should not stay home, who clearly needs to go to the ER or call 911. And if it's delayed, if it's severe, if they've had a severe reaction before, if there's any question, any concern, any worry, then go, right? Why? Don't hesitate to go. But for some people who have anaphylaxis and are familiar, it seems to be fine to stay at home. So that was new last year. All right. So that is kind of the end of that. Hopefully that helps with recognizing diagnosing, calling it, providing epinephrine if they have it, and then if you decide to treat with other things and you want to give a histamine blockade and give cetirizine or nidine, that's great. If you want to give a little prednisone for a couple of days, that's fine. It doesn't seem to help biphasic. And for biphasic, it's those patients that had a severe reaction. Those are the ones you got to worry about. If they did severe, they didn't get epi right away, something kind of odd about it, you don't even know what caused it. Those are the ones that you really have to worry about. This is the change that just happened. So just a little while ago got approved. I don't work for them, but it seems to be a really nice option. So this was done based on mostly pharmacokinetic studies, and I'll show you that in just a second. But so it's neffy is the brand name, and it's just epinephrine. If you're curious about the pharmacokinetics, this is, how much gets in. So when I provide this, how much gets in, most of the data was done on healthy volunteers not having anaphylaxis. You can compare it. Nasal is the green. Yellow on the left is giving it IM, drawing it up in a syringe and giving it. Like in the allergy clinic, that's how we did it. We had syringes on the inside of every door, and then giving an epinephrine auto-injector. All right. So those are the three options, and very similar pharmacokinetics. I don't have a pharmacodynamics data slide, I don't think, but the blood pressure changes, heart rate changes, and then just, that would seem to be very, very similar between the three. So you can kind of see how that happened. This is the device. I've got it here. I don't kind of see it. And you can see it in the middle there. This would never happen. This isn't possible without help. So the amount of epinephrine that would need to be administered to the nose to make this work was too much. It wasn't practical until the addition of Intravale, which is not a medicine. It's just it's a cofactor that allows the absorption of medicine. And pharmacy people could chime in more on that, but increases the movement of medication across the mucosa and greatly enhances absorption. These other products use the same plastic device and the same Intravale. You can see on there the diazepam and the sumatriptan using that same thing, okay? And you're familiar with Narcan for the device. So this is how it's delivered. It has a helper that gets it in quicker, and it's a single dose administration. This is some of the data, again, more on it. It lasts for 30 months, so that's a little longer than epinephrine auto-injectors. The temperature swings seem to be better for this. I mean, if it gets frozen and thaws, it's fine. And I mean, you don't want to get it up to 122 degrees, but it did fine up to that. So in your car on the dash in the summer should be okay. No training, same as Narcan. And you just administer, you just insert and press. That if you're curious about the instructions, how to actually do it, that'll walk you through it. This is available. And I was going to say for schools, they just last week, ARS, the company that makes this, they're going to have neffy for schools. You can get these for free to your schools. In fairness, epinephrine auto-injectors, EpiPen for schools does the same thing. And if you need help with that, I'm happy to help. I don't know with neffy if you need a prescription. With epinephrine auto-injectors, you did up until last. I think you still do. So I'm happy to provide that if that's something you're interested in at schools. I'm happy to help. But you can get this, and you are protected to give that to anyone that has a reaction. So this is how to. It's given in the same nostril. If you give a second dose, it's in the same nostril. Even if they have allergic rhinitis, you still give it, and it works just actually a little more got absorbed with allergic rhinitis, which is interesting. But out there, very small. Cost, I don't know about the cost. I don't have data on that, but there's programs already to get it there'll be coupons like normal, and they have a program if you can't afford it all. So that's important. So anyway, that's an option, and your patients are going to ask about it. And right now we can say is it works the same. It seems to be as protective, smaller, and there's no needle. So no hesitancy. That's the hope. If you want to chart with all of these, this is on the Asthma Allergy Network. There's no charge for this. You can go to that link below. That's a nonprofit group that puts out these and the inhaler posters. So that's kind of interesting, and how to contact them. And oops, I went too far. But anyway, that last thing was also from them. And if you're curious more about just kind of having this as a review but on the right side, you can see it says epi first, epi fast. And that's the key. Recognize, diagnose, call it what it is, provide epinephrine, activate EMS if that's appropriate, monitor them. And then when they come back, talk to them, make sure they have what they need, either an injector or a nasal device. And get them over to allergy, because we can help a lot of times figure out what's going on. And there's an anaphylaxis emergency plan. So if you want a written plan to provide your patients, that's the Quad AI, that's the American Academy of Allergy and Immunology, the physician group, and they have that. I think that's it. So I will stop there and see if we have any questions.
Okay.
So,
Thank you. That was so great. Oh, look, we already have questions. Go ahead. Go.
Good. I like it.
Brian, there were a couple of questions in the chat that I responded to. One was the recommendation to use ranitidine, which is no longer available on the market. So using famotidine instead.
Yeah.
And then the other question, and I'm interested to hear what you think about it, is using an expired epi kit, right? People hang on to them because they don't have to use them, which is ideal. And I would say, like, we don't want to recommend using an expired one, essentially because if they haven't been stored correctly, if they've been carrying around in backpacks, freezing, colding, those sorts of things. However, in case of emergency and you don't have anything else, it's probably best to give it, right?
Yeah.
As long as when you look at it, the solution is clear, those sorts of things. But always recommend making sure that people keep looking at their expiration dates.
Yeah. I newest first, so you're always going to use the one that's newest first. I recommend not throwing them away though. If you have extra, put it in the pickup or at grandma's house or whatever, but you're always going to use the newest first. But there's pretty solid data that even 7 and 8 years out, in fact, there is very good data that it's still mostly effective, 90-ish% effective. So they're very expensive and most people let their prescriptions lapse, as you know. And so use the newest first. But if you want to keep those around, if you hold up to the window, that little clear window on the auto injectors, if that's cloudy, then that's a good time to go ahead and toss those. But man, it's just having them, where you can get to them is super important. Yeah, totally agree.
As I am reading through the chat, Ian has a question, so I'll let you start and then I'll look through what we have in the chat.
Thanks a lot, Brian. That was a great presentation. I was wondering when I got the slides, like if nasal congestion would make absorption of this stuff worse. And I was trying to find stuff on PubMed to see if that had been tested. And I found something indicating that it seems like nasal histamine response actually improves the absorption of this intranasal epinephrine. Is that accurate, or anything else about nasal congestion or boogery kids or anything like that?
Yeah, it is accurate. So the trials were done inducing allergic rhinitis. So I know you're allergic to cat. Let's squirt some cat up your nose, which by the way smells like wet cat, and inducing an allergic rhinitis response, and then giving the medicine and following it. And yeah, it did. So, and it kind of makes sense retrospectively because it's boggy tissue that gets more boggy, and you have vasodilatation already happening. So you have more surface area and more blood flow to the area. So allergic rhinitis, runny, all that kind of stuff. It's not better, but but the absorption seemed to be better. So don't hesitate. If you do give one dose, then the recommendation, and you need a second dose, is give it in the same nostril because you already have that intravale in there. And so you get like the second dose is actually absorbed better than the first. So that's good to know. There's no data on septal deviation, if somebody has a blockage from a trauma or whatever, that's a time where I would not provide it because it just makes sense. If it can't actually get in physically, there's a blockage, that would make sense. But boggy, runny nose, allergic rhinitis, even with polyposis, I don't think there's any reason to hold that back at this point with the data we have.
Okay, thank you. There is a question in the chat from Lee Cornfield. Did you want to unmute to ask?
Sure. My question was related to biphasic response. Realizing there's many contributors, once a person experiences that, are they more apt to have such a similar experience going forward?
Yeah, in short, yes. It is the case. There was a couple of times when if it was idiopathic and that trigger was figured out, the risk, then that was mitigated by avoiding or whatever. So that was different. But for everyone else, yes, the risk of a previous biphasic reaction does increase the risk. And I think it was 1.6, if I remember right, the odds ratio. But the reference I have on there, you can see it. They have a very nice table. I only provided a few of those, but yeah, it was a risk factor for sure.
And maybe a follow-up, something different, Anaphylaxis. So epinephrine has been available for decades. And realizing this is a kind of a newer type of delivering implement, let's say, any concerns or any possibilities of getting generic epinephrine, adrenaline, compounded or whatever at pharmacies, worried about safety and effectiveness, but also much lower costs. Any of that coming to fruition or a possibility?
Yeah, I haven't seen anything. I mean, and I think, yeah, I would be honest. If I told you the things we did in the allergy clinic to get around the epinephrine autoinjector and how we provided things for patients, which I won't say on here in case anybody's watching, but we tried, so there's ways, but I think that's very interesting. I would not know how that would work because you have to enhance absorption for it to get in the bloodstream. Providing epinephrine nasally doesn't work. And so you have to have an adjunct to get it in. And so, yeah, I hopefully ARS, they seem to be doing a really good job of trying to make it affordable for almost everyone. And I think if you have commercial insurance, the cost will be probably, I think, in the $20 to $30 range, kind of like everything else that we have right now, right? If with coupon. And then if you don't have any commercial insurance, there are ways to get it at no cost. So yeah, but it's a good question. And I think somebody will find a way to try that out probably.
But I will say, like, the challenge of being able to get it at a compounding pharmacy, right? The reason why compounding pharmacies are able to provide medications it is that they're able to provide it in a way that is not commercially available, right? So all of the GLPs that people are getting at compounded pharmacies are coming in vials. That is not commercially available. Everything in a GLP is commercially available in a pen device. So a pharmacy would have to create a different sort of delivery device to be able to provide it compounded. And so I think the nasal spray itself probably isn't really feasible for most pharmacies.
And it would be pretty scary too. I think.
Yeah.
Yeah.
Okay, so we do have some more questions coming in. Nina, I know had a question, so you can go up next, and I'll keep an eye out on the chat for other ones.
Brian, thank you so much. I just love you. That was such an engaging
I'll send you that.
presentation, and it was really helpful. I haven't looked at some of that stuff for a little while, so it was really practical, which sounds like your goal. So thank you very much. My question is about, well, I have a couple of different questions, but one that comes up frequently for me in clinic is I have patients who will come to me and say, I'm going out of town or I'm going on a trip or something, and I've had allergies to something in the past, and I need a prescription for an EpiPen. Any hesitation to be giving prescriptions for, EpiPens for patients like these? It doesn't sound like it. It sounds like, there's really such little reason to not have somebody have Epi on hand. Any reason to not give these prescriptions liberally?
So you're a patient that doesn't have a history of anaphylaxis, but yet requests an epinephrine. Yeah, I would actually say don't do it. I mean, that's my
Okay.
I would not because of the risk of the medication, but because it's kind of like doing food allergy tests on the blood, serum tests. Like, just please don't order those shotgun. They don't help. They're misleading, and there's so much misinformation. So, I have a positive test to asparagus. Now I don't need asparagus, but you're really not allergic to asparagus, right? So in this case, and it's the same reason we don't like just give it to people that are beekeepers without a history. You would think, well, I'm exposed, but we need to find out and provide appropriate medications for known, severe allergies. So I think it muddies the water. And I always wonder like where those EpiPens end up anyway. And also just relying on a medication that's really not appropriate for what they have, in this case, allergic rhinitis. So I would lean heavily against ever doing that when the diagnosis is unclear. Now, I would say this, if like, man, we think this might have been anaphylaxis, we're going to have to figure this out. It's going to take a while. Okay, like you really have a good reason to get it. And at the same time, we're going to dig in deeper and it's going to take a while to get to allergy. That is fine. In fact, I would much rather that happen. But then there's a clear, a reasoning is this may have been an anaphylactic event. Let's go ahead and cover you while we're figuring it out.
And there's a follow-up question to that here. So just out of curiosity, on a personal level, you don't recommend food allergy testing? How come?
So serum testing. No, I very much recommend in appropriate patients doing skin prick testing or doing allergy testing. But if a patient came in and I ordered a panel of 20 food allergy tests in the blood, that test is, and they don't have, like, they didn't eat a blueberry and get a high. So there's no reason, there's no one, that those are completely, not only are they not helpful, they're actually very harmful. They do not tell you, blood tests cannot tell you if you're allergic to anything. It's not possible. Having an antibody to blueberry does not make you allergic to blueberry. And so we end up avoiding foods we didn't need to avoid, worrying about foods we didn't need to worry about, and maybe not treating something else that needs to be treated. So serum testing is okay and helpful in certain situations when the pre-test probability is high. I ate a strawberry, I had hives all over my face. I'm going to get a serum test for strawberry because there's a history here and it makes sense. And I want to see what's going on, and it'll help guide me whether I do a food challenge or a skin test. But shotgunning those things is harmful, expensive, and never gets you where you need to go. Answering the question, do you have a food allergy? That's the question. And I can't tell you that with just a serum test and no other factors.
Thank you. Continuing with questions that are popping up. Someone wants to know if you can do a quick recap of the treatment for biphasic.
So the treatment's the same. So if somebody has a reaction, we treated them, you treated them, I treated them, and now they have a biphasic. So it would be the same thing, deciding whether they need administration of epinephrine, deciding what you want to do. The question would be, are they done? You had a reaction, it's 4 hours later, you had a second reaction. I don't know what's going to happen. Is this going to be a prolonged course? So those patients are usually going to be seen in an emergency situation. They're going to maybe get an epinephrine drip or just monitored. And in the allergy clinic, they were just in our clinic all day. We had a room for it. We had a protocol for that. It's not anywhere. And then we can just kind of watch them and see. And then at the end of the day, decide if they need to go somewhere. But that's a very specialized, but treat the same, monitor, and decide how best going forward to make sure this is it. Because you had 2, I don't know, maybe we're gonna have 3, or maybe becomes just a prolonged, anaphylactic event like those first couple of slides I showed. So it's the same treatment, but just watch them.
Thank you. Another question. Does anyone have a well-developed process for getting these medications for schools to have them on hand and staff trained to use them when needed? Programs for free supplies, question mark.
Yeah, so epinephrine, EpiPen for schools. So if you go to that website on that last slide I had, or ARS, they just announced it. So ARS does have a thing where you can sign up. Both of them will give you free product. ARS for Neffy is not going to happen until January of 2025, but EpiPen for schools does have it. You get the pens, you get, I think, 4 juniors and 4 regulars, and it comes in a little box that you can put on the wall. And if you do ever need help with that or training, I'm happy to do that. There's others that can do it. I know there's a nurse that works for Boise Schools that does it. So happy to help out. But if you go to their websites, you can get that information. And they're pretty good about getting that out to you.
Okay, so that's, I think, the last questions in the chat. We have time for one more question if anyone has a last question. Ian, go ahead. Oh, and Glenda. If there's time, we'll get you both, but if not,
I had a question about alpha-gal. Glenda, if you have something that's more on topic. But the question I had about alpha-gal is, I've heard that tick bites are associated with the development of alpha-gal. Is that still what we're thinking is causing the majority of alpha-gal things?
Oh, yeah, all of it. Yeah. You have to have exposure through a tick bite, the Lone Star tick. And without that, there's no known alpha-gal, although there's people like in Hawaii that say they've never left and they have alpha-gal. So maybe there's something else that we don't know. But the Lone Star tick, pretty much in the south, more in the east, but it's coming north as climate change. So yeah, so right now that's our thinking. You have to be exposed. The tick injects you with starts the process for making an antibody to mammalian meat, so to red meat. Then you have that antibody, but the meat has to be broken down for you to respond to it. So that's why you ingest it. It goes through, you chew it, you get to the stomach. There's some degradation with proteases, and then you have enough exposure to the right part of the protein to have the reaction, and then you have this late delayed anaphylactic reaction. And a lot of times it's really GI heavy, which makes sense. But yeah, so that's what it is. You have to be bit by the Lone Star tick, which we don't have in Idaho so far.
Well, thanks a lot.